Hi everyone, my name is Lakshmi and I'm going to be doing a presentation on the equipment used in a TLH. This is not going to be a comprehensive list, so I wouldn't use it to stock an OR, but I'm going to try and go through all the main equipment that I saw when I observed a few TLHs over the course of this SSM. So to start off with, a total laparoscopic hysterectomy, or a TLH, is a gynecological surgery which involves removing the uterus and cervix using a keyhole technique, so laparoscopy. Sometimes additional procedures are added on, such as the bilateral salpingo oophorectomy, which is removing the ovaries and fallopian tubes, and sometimes pelvic lymph nodes are also removed in conjunction. Reasons for a TLH can include heavy or painful periods, fibroids, gynecological cancers such as endometrial or ovarian cancers, and the procedure is usually carried out under general anesthesia. Patients can usually go home the next day if they're recovering well from surgery, but again, this depends on how well each individual patient is recovering. So to start off with, there's some equipment that is used across most surgeries. This isn't specific to gynae surgeries, but surgical drapes, drape clips, adjustable surgical table, anesthetic equipment like the intubation tubes, laryngoscope, and the anesthetic trolley, which I have pictured. And then prep equipment such as pink chlorhexidine or betadine. And the gynae data is here. I've seen them use pink chlorhexidine, but they could use pretty much anything. And they use a swab and forceps to apply the prep solution. Additional things that are a bit more specific to the TLH is a bean bag, which they use to stop the patient slipping down the back of the trolley, as they usually have the patient in a Trendelenburg position. But that is, again, here at Derby Hospital, and this may not be everywhere. First of all, they visualize and clip the cervix. So once the patient is prepped and on the table and in the correct position and sanitized and everything, they use a sim speculum to visualize the cervix, and then they use tenaculum forceps to clip the anterior and posterior lips of the cervix. At this point, they do insert a Spackman cannula. That's what they use here at Derby. They may use other equipment elsewhere, and they insert the Spackman cannula into the vaginal canal and then into the uterus. But I will come on to this a little bit later and explain that in a bit more detail. So once you have visualized the cervix, clipped the cervix, inserted the Spackman cannula, then up at the abdominal end, once you have prepared with your pink chlorhexidine or betadine, then you prepare the telescopic port site. So here I have seen them used local anesthesia of levobupivacaine. Don't know if I'm saying that right, but that's what they've been using. And they use a needle and a syringe to administer this, usually subcutaneously, I would like to say, but this could be wrong. And the port they use for the scope is usually the umbilicus, as that gives the best access to the pelvic and abdominal organs. However, sometimes if this is not possible, then they can go up to Palmer's point, which is another surgical point, or sometimes they use the supraumbilical point as well. We had a patient who had an umbilical hernia, and the Palmer's point was used instead. So that is the first site that is prepared for port insertion for the scope. The next step is to insufflate. So insufflation is the introduction of carbon dioxide into the peritoneal cavity to produce a pneumoperitoneum. The pressure is usually increased to about 20 millimeters of mercury for the port insertion, and then dropped to a level of approximately 8 millimeters of mercury for the rest of the procedure. But again, it depends, and it varies from surgeon to surgeon what pressures they like to use for each part. But this is just the ones I've seen most commonly. The carbon dioxide is introduced using a spring-loaded needle called the Verus needle. So what they do is the surgeon will first make a small incision with the scalpel and hold the incision open with the forceps. Some surgeons, I've seen them use the back of the scalpel to then open this incision a little bit further bluntly rather than using the sharp end. And then they will insert the Verus needle at either a 45-degree or a 90-degree angle, depending on the body habitus of the patient. I believe 90 degrees is the correct or traditional way to do it, but sometimes they use a 45-degree angle. Gas tubing is also attached to the Verus needle so that the carbon dioxide can be introduced into the peritoneum. The Verus needle can have different lengths and diameters, and it has a hole in the side of the needle rather than at the tip of the needle, and this is so that it does not get blocked up when the needle is being introduced into the abdomen. The next step would be port insertion. So ports are usually a trocar and cannula system, and the trocar is usually bladed at the end, but with a retractable blade, I believe, so that once the trocar has gone through the layers of the abdomen, it then retracts so that it does not affect any structures below. It can have different shaped tips. So the ones I've seen most commonly in the Derby theatres is the pyramidal tip, but you can also have conical, blunt, eccentric. The trocar and cannula systems can come in different shapes and sizes. They can have different diameters, different lengths. The most recent versions that are being used are plastic cannulas, but I believe that previously they used to have metal ports and cannulas. The cannulas have a balloon at the bottom. Well, some of them do. They have a balloon at the bottom that can be inflated once the port has been inserted so that the port does not come back out when you're using surgical instruments. However, like I mentioned, they can vary with shape and size. So some of the robotic ports, some of the ports I've seen used in the robotic surgeries don't have balloons, so they do run the risk of coming back out when the laparoscopic instruments are being used. At the end of the surgery, the balloon is then deflated and the port is then removed successfully. When inserting the trocar and cannula, you do not have to use much downward pressure. It's rather a twisting and rotating motion, sort of like this, rather than pushing down. And this helps because the edges of the tip are used to slice through the tissues. When you are inserting the port goes through the skin, then the subcutaneous fat, then the anterior fascia, then the rectus muscle, then the posterior fascia, and then the peritoneum. Gas tubing is attached to the port after insertion so that the intraperitoneal pressure can be maintained at the desired level. And I believe they now have devices called air seals that can prevent gas escaping and maintain the pressure at the desired level. Once you have inserted that first port, it's usually at the umbilicus. Then the telescope or the scope is inserted into the prepared port site. The scope can come, again, varying diameters and lengths, and also varying angles at the tip of the scope. So some surgeons like to use the 0-angle scope, and some surgeons like to use 0-degree angle, and some surgeons like to use different angles, so maybe 5 degrees, 30 degrees, whatever they prefer. The angled scopes allow for better visualization, so even if you're going down at a 90-degree angle, you can still see at an angle into the abdomen or the peritoneum. Or the peritoneal cavity, sorry. The scopes have a light attached to them to aid visualization of the peritoneal cavity, and a scope warmer is used to prevent lens fogging on insertion. A scope filter is also fitted to reduce the interference with the image, and a white swab is used for white correction so that the colors appear more natural, as the light you are inserting is quite a bright white light. A wire cover is also used to maintain sterility as well. So next is the laparoscopic instruments. I can't name all of the different heads, but as you can see, there are a multitude of different heads and also different handles as well. The instruments are light and well balanced. There is a smooth rotation of the jaws using this feature here. You can twist it within your hand so that it can rotate the jaws of the instrument. There's comfortable, easy open and close handles, and the instruments can be double or single hinge. These instruments are usually single use only. And next up are the energy devices. So you can have monopolar, bipolar, advanced bipolar, and ultrasound instruments. Those are different modalities. Monopolar, you can have things such as the diathermy pencils. I couldn't find an example of the simple bipolar, but the advanced bipolar, you can have the NSEAL by Ethicon, and then the ultrasound, there's the harmonic, also by Ethicon. Those are the most common ones used in the Derby theatres. But again, this can vary from trust to trust, and surgeon preference can change from surgeon to surgeon as well. So in the theatres that I've seen, they most commonly use the harmonic, which is the ultrasound instrument, for the majority of the dissection of the structures away from natural anatomy. But again, it varies from surgeon to surgeon. I've also seen surgeons use the advanced bipolar in surgeries quite a lot for any extra coagulation, as I believe the coagulation is a little bit better on the advanced bipolar. For monopolar devices, the circuit is completed by using an electrode pad that is attached to the patient. But for bipolar devices, the two jaws of the instrument itself complete the circuit. And surgeons can use more than one within one surgery. They can use a combination of them, and it just depends on surgeon preference. So like I mentioned earlier, a Spackman cannula is inserted into the uterus. This can be used to manipulate the uterus, so to antevert it, retrovert it, and move it from side to side. This allows the surgeons to access certain areas of the organs a little better. So if you antevert it, the surgeons can access underneath the uterus. If you take it to one side, they can access the fallopian tubes a little bit better. It provides a little bit more tension so that they can grab the fallopian tubes better, so on and so forth. Once the cervix has been breached, so once they have dissected the cervix, you run gas starts to leak from the peritoneal cavity out of the vagina. So at this point, the Lena-McCartney tube is inserted with some lubricant, and the holes at the end have valves so that the air cannot escape. And then you can, once the whole uterus and fallopian tubes, or whichever structures you want to remove, have been fully dissected away, you insert your laparoscopic forceps through the smallest hole of the McCartney tube. And again, due to the valve, the air does not escape, but you can insert your forceps, and then you can grab the structures that you want to remove, and you can remove both the tube and the forceps at the same time, so that everything is removed through the vaginal canal. Once you have removed your structures and placed them in a specimen pot and labelled and sent them off for preservation and testing, the McCartney tube can be reinserted to the vaginal canal, and it can be used to again manipulate the remainder of the vagina so that the surgeons can access the top lip of the vagina and sew it up from the inside. Another thing that is also used in conjunction with the McCartney tube is a large wet swab on the vulva to prevent the carbon dioxide gas leaking. That is everything here. One of the final steps is suturing. So once you have inserted that McCartney tube back in and you're using it to manipulate the top lip of the vagina again, and all your other structures are removed, laparoscopic needle holders and sutures are used for sewing up the top of the vagina. In the surgeries I have seen, they like to use the V-lock suture, which is a special type of barbed suture that does not require knot tying, and it eliminates the need for that, as it can sort of hold the structures together without needing to be knotted due to the barbs, which prevent the suture slipping back. And the laparoscopic needle holders are here. They can lock onto the suture without needing additional pressure or force from the surgeon. And again, these are used to sew up the vagina. And then you also have normal needle holders and sutures for sewing up the port entry sites once the ports have been removed. The surgeons I saw, Mr. Abdul most commonly uses the 30 PS monocryl suture, but again, this is surgeon dependent for both actually. The V-lock and the normal suture, it is completely surgeon dependent which sutures they like to use. A lot of the surgeons I saw like to do the sutures for the port entry sites. They used to do hand knots and hand tying rather than using instruments, but again, very surgeon dependent and surgeon preference. In summary, this is a list of the equipment that I saw Mr. Abdul use most commonly for his TLHs and BSOs. But again, it is very surgeon dependent and also trust dependent as well, depending on what equipment is available and what the surgeons like to use the most. But this is just a list of what Mr. Abdul liked to use.